Welcome to the Radonc Smart Review Head and Neck Cancer series.
Today, we are opening Supportive Care 1, focusing intensely on dental, nutrition, and mucositis management in the head and neck cancer patient undergoing definitive radiation therapy.
And this really marks a critical pivot for us.
Yeah.
For the last several discussions, we've spent all our time and energy on, field design, dose constraints.
All the technical stuff.
All the technical aspects of, how to kill the cancer. But today, the focus shifts completely. We're talking about something softer, but I think fundamentally more critical.
It's how to keep the patient alive and well while we do it.
Exactly. This is our essential guide, kind of the don't lose the patient discussion.
And this transition from pure physics to actual clinical management, this is where the great differentiators are made.
Oh, absolutely.
Especially when you're sitting for your oral boards, a candidate who can, perfectly recite a 46-grain nodal contour.
Right.
But then they hesitate. You ask them about the timing of a tooth extraction, or maybe they show poor judgment about a PEG tube placement.
Or they just don't have a plan for that crushing grade 3 mucositis in week 5.
Exactly.
Right.
That immediately advertises a huge gap in real-world clinical experience.
It really does. Supportive care mastery isn't just about patient comfort. It's about cure, the ability to manage these things proactively.
Yeah.
It's the difference between an attending who deals with, 1 or 2 urgent PEGs a year.
And one who's managing 10 of those crises.
Right. We're moving from planning fields to, setting the patient's life raft in place. This discussion is really your pre-treatment checklist, your on-treatment playbook, and crucially, the red lines you just do not cross.
Yeah, if you want to set the patient up to actually finish treatment successfully.
And avoid those devastating long-term problems.
So let's anchor this whole thing with a mini clinical case. That classic 58-year-old male who walks into the clinic.
The kind of thing that opens a board station and just forces you to show your clinical judgment right away.
It links the technical knowledge to the support of reality.
Okay, let's run the case. So you are consulted on a 58-year-old male patient. His diagnosis is a T3N2B AJCC 8th edition P16 negative squamous cell carcinoma of the base of tongue.
And as you're looking at his chart, the high-risk features they jump right out at you. He's a current smoker.
Huge red flag for toxicity right there.
And crucially, he's lost 15 pounds in the last 2 months. That is a serious indicator of baseline dysphagia. He has no nutritional reserve before we've even delivered 1 fraction of radiation.
And then on exam.
On physical exam, his dentition is, it's alarming. He's got multiple large caries, several loose molars, and they fall directly within your planned high-dose radiation field.
So the proposed plan is, of course, definitive concurrent chemoradiation with high-dose cisplatin, the gold standard. And the consult question from the referring service is so simple, so urgent, but it's just loaded with clinical risk.
Can we start radiation on Monday?
Exactly.
Okay, so here is how you have to deliver that 60-second board script response. This shows you recognize all the critical non-oncologic risks that really they mandate a pause before you even begin.
I would say. This is a patient with locally advanced P16 negative base of tongue cancer requiring definitive concurrent chemoradiation. Before starting therapy, I need a robust supportive care clearance plan because his dentition is poor and he has significant pretreatment weight loss.
Specifically, he needs urgent dental oncology evaluation with imaging, and any non-restorable teeth in the high-dose region must be extracted before radiation therapy with adequate time for mucosal healing, typically at least 10 to 14 days minimum, ideally closer to 2 to 3 weeks when feasible, to reduce the risk of osteoradionecrosis.
Furthermore, he is high risk for nutritional failure, given the baseline weight loss, base of tongue site, planned bilateral neck treatment, and concurrent cisplatin. Therefore, I would involve nutrition immediately and strongly consider a prophylactic feeding tube strategy, APEG, while emphasizing swallow preservation exercises from day 1.
Conclusion. Radiation should not start Monday. It starts after dental clearance, a coordinated nutrition plan, and a realistic schedule that prevents avoidable treatment breaks that would compromise the chance for cure. That response confirms that you prioritize the patient's ability to complete and tolerate the therapy, not just the technical start date.
Okay, that's perfect. Let's unpack that because, that response basically dictates the next several weeks of this patient's care. We have to start by understanding the anatomy and the workup, but through a totally new lens.
Right, the lens of toxicity, which leads us right to the pretreatment checklist.
Exactly.
The standard workup is all about finding the tumor. Here, We have to pivot our anatomical knowledge to anticipate and really to predict the collateral damage. So, which specific anatomical sites or treatment features confer such a high risk that they just immediately justify aggressive supportive care?
Well, primarily, it's the location of the primary disease. So number one, primary sites involving the base of tongue or the hypopharynx.
Massive risk factors for morbidity.
Huge. If you treat those areas to a curative dose, the pharyngeal constrictor muscles, which are absolutely essential for swallowing, they're getting a massive dose hit. And that directly leads to severe acute dysphagia and, a huge risk of long-term fibrosis.
Yeah.
And that's before you even account for the neck.
And that's number two, right. You have to look at the field sizes, the nodal coverage. Planned bilateral neck irradiation means, well, it means extensive mucosal dose to the oropharynx, the hypopharynx, often the entire mucosal axis.
It means high dose to both parotids. We're talking 70 gray or more sometimes.
Which drives that debilitating xerostomia and radiation caries. And it means you're covering nodal levels 1 through 6, often the retropharyngeal nodes. The point is, the larger the mucosal volume treated to a high dose, especially above 40 gray, the worse the mucositis.
And the worse the long-term fibrosis and stricture risk will be.
Exactly.
So we define high risk not just by T or N stage, but really by a combination of all these clinical features that predict nutritional failure and severe toxicity. Let's lay those out for everyone.
Okay, so if a patient has baseline weight loss, and we flag anything over 5%, but especially if they've lost 10% or more in the last few months, that's a huge nutritional red flag.
They're starting the race already dehydrated and malnourished.
Right. And if they have documented baseline dysphagia or odynophagia, a history of aspiration before they've even seen a radiation beam, their reserve is 0.
And you mentioned site base of tongue or hypopharynx. We just classify them as high risk by default.
By default. And then you have the systemic therapy overlay. If we're adding concurrent therapy, particularly high-dose cisplatin, this acts as a profound radiosensitizer.
It doesn't just increase tumor response.
No, it amplifies everything.
Right.
Mucositis, nausea, dehydration, it's exponential. A high-risk patient on cisplatin is fundamentally different from one on, say, weekly cetuximab.
And we can't forget the social stuff, the logistical determinants of health. Poor social support, transportation issues that make daily treatment a 3-hour nightmare.
Or a patient who lives alone and has no caregiver to help with food prep.
All of that means they're way more likely to crash, to miss fractions, and end up in the EDD in weeks 4 through 7. We have to screen for this.
Which brings us to the mandatory steps before the first fraction. The absolute non-negotiable pre-treatment checklist. The goal is simple.
Set the patient up to finish.
Exactly. And prevent those totally preventable emergencies that just derail the entire curative plan.
Okay, first, and this is often the rate-limiting step, dental clearance and an extraction plan. If they need work, they need time to heal. Period. This often dictates your start date.
Second, a baseline nutrition assessment and a mandatory visit with a dietitian. We need to know their starting weight, their caloric intake, and we need a personalized plan to monitor and escalate that intake every single week. It's an active plan, not a one-time consult.
Third, swallowing function assessment and therapeutic exercises with speech-language pathology, or SLP.
It's physical therapy for the throat.
It really is. Starting those exercises before the injury occurs gives them the best shot at long-term functional recovery.
Fourth, a serious, dedicated smoking cessation plan. Ongoing smoking during radiation. It just dramatically worsens acute toxicity, impairs healing, increases the risk of complications.
And is associated with worse overall outcomes.
Right. We need to offer aggressive nicotine replacement or meds here, not just a casual suggestion.
Fifth, a proactive pain plan and an antiemetic plan. Don't wait until week 4 when they're in agony and vomiting to think about this stuff. They need scripts for opioids, antiemetics, maybe some adjuncts before treatment even starts.
With clear instructions on when to escalate.
Absolutely. Sixth, mandatory baseline labs, especially renal function, CBC, complete metabolic panel to watch the kidneys with cisplatin, and a baseline audiogram if high-dose cisplatin is planned.
Because those cochleas are going to get stressed.
And finally, the social and logistics check. Transportation, caregiver support, making sure they understand this is a 7-week commitment. This entire checklist is your defense system against the most common causes of treatment failure.
And if you skip a step, the patient will remind you in week 5.
Yeah, they will.
Okay, let's spend some real time on that first and most immediate hurdle from our case. Dental clearance and ORN prevention. This is where a resident can often fail the judgment test because it means delaying treatment.
And we need to nail the pathophysiology first. Why is a tooth extraction after radiation just a ticking time bomb? We often talk about the 3 H's.
Precisely. So high-dose radiation to the mandible and maxilla permanently injures the microvasculature of the bone. This isn't temporary inflammation, it's a progressive, permanent obliteration of the blood supply. That's hypovascularity. This makes the bone tissue hypocellular. It loses its native ability to turn over and repair itself, and therefore it becomes hypoxic, starved of oxygen. The ability of that bone to remodel, to fight infection, to heal a wound, it's just permanently gone.
Sometimes for decades later.
Decades. So if a patient gets, say, 70 gray to the jaw, and then years later they need a tooth pulled, that trauma, that open socket, it just never heals because the biological repair machinery has been destroyed.
And that non-healing exposed bone is osteoradionecrosis, or ORN.
It's a terrible complication. Chronic pain, unrelenting infection, pathological fracture risk, often leading to devastating reconstructive surgery.
Which leads right to that mandatory quotable board line that shows you get it.
Right. Dental extractions before radiation therapy, not during, not after, because ORN is a jaw dose problem, not a tooth problem.
That reframing is so key. The problem isn't the tooth itself.
It's the jaw's permanent inability to withstand even minor trauma once it's been irradiated.
Okay, so let's detail the mandatory workflow for every single head and neck patient.
First step is the referral. Any patient whose plan includes significant dose, let's say over 50 gray to the mandible or maxilla, they need a specialized dental oncology evaluation.
If you don't have one.
Then a highly experienced oncology-aware dentist or oral surgeon is mandatory. Don't rely on a general dentist who's never seen an irradiated mandible.
So the workup is a thorough physical exam focusing on periodontal health, mucosal integrity, plus imaging. A panoramic radiograph is usually the standard, right?
It is. It gives you excellent visualization of the alveolar ridges and the entire mandible, which is the most common site for ORN.
And the decision is then to identify any non-restorable teeth, or teeth with a poor long-term prognosis that are sitting right in the high-dose region.
Exactly. Non-restorable means significant caries, periodontal disease, severe mobility. We're not looking for cosmetic perfection here. We are ruthlessly eliminating future sources of trauma and infection in that irradiated field.
Now, the pivotal concept,
Yeah.
timing. We're delaying a curative cancer treatment, so we have to justify it. You need a healing window.
Yeah.
What are the key variables here?
The practical absolute minimum for small, simple extractions is 10 to 14 days. That's for soft tissue mucosal healing over the socket to make sure the raw bone is covered. But that's a minimum.
Right.
We need to counsel the patient that if they have larger extractions, poor baseline health like diabetes, or if they're still smoking, or multiple extractions, we should strongly aim for 2 to 3 weeks if we can get it.
Because starting radiation on fresh open sockets just increases the risk of pain and infection.
And subsequent ORN. The delay is curative medicine.
This issue also leads right into long-term dental protection because the damage mechanism, the salivary gland destruction, it continues long after treatment ends. This is the problem of radiation caries.
Right. Radiation causes permanent, irreversible damage to the parotid glands, the minor salivary glands, leading to chronic xerostomia or severe dry mouth,
The patient loses that natural rinsing action of saliva.
which neutralizes acids, washes away food particles, the oral pH drops, and dental decay just accelerates dramatically. Sometimes they need all their teeth extracted within just a few years of treatment.
So we have to stress that proactive, high-dose fluoride application is non-optional. It is mandatory for life.
And the precise prescription matters. It involves custom-fitted trays.
Not the store-bought whitening trays.
No, custom-fabricated dental appliances plus a high-concentration fluoride gel. We're talking about things like 1% neutral sodium fluoride used daily for 5 to 10 minutes. It's fundamentally different from what's in commercial toothpaste.
And the duration is crucial and so often missed. This is lifelong when salivary dysfunction and dental dose exposure are meaningful.
Which is basically every patient getting bilateral neck radiation. If they got bilateral parotid dose over 50 grays, they have to assume this is a permanent requirement.
Because failure to counsel on this leads to long-term dental ruin.
Yeah. If you recommend fluoride for 6 months and then stop, you've completely misunderstood the permanent nature of the vascular damage and the salivary dysfunction. That 6-month recommendation, it's a classic board trap that just screams inexperience.
Yeah.
It has to be lifelong.
Okay. Moving on to the second pillar of supportive care, nutrition. We need to be aggressive here. Why do we elevate nutrition to like an oncologic priority instead of just a secondary support service?
Because the evidence is just overwhelming. Malnutrition and dehydration are the primary drivers of treatment failure in head and neck cancer.
They lead directly to treatment breaks, dose reductions.
Missed chemo cycles, hospitalizations, aspiration events, and, demonstrably worse long-term survival and quality of life. If you wait until the patient is symptomatic in week 5 to react, you have already lost the battle.
So our proactive risk stratification really dictates our approach to feeding access. We need to nail this discussion around a prophylactic PEG versus a reactive tube. This is a huge favorite on oral boards.
It is, because it has clinical nuance. When you discuss this, you have to frame the decision based on risk. The prophylactic strategy means placing the PEG tube early before treatment or in week 1, specifically for those high-risk patients.
You're trying to preempt that inevitable crash that hits like a truck around weeks 4 to 6.
Right. The argument for prophylactic placement is avoiding the acute crisis, preventing unplanned treatment breaks, and making sure the tube is placed under stable conditions, not in a panicked emergent situation later.
And the reactive strategy?
Conversely, that means monitoring the patient rigorously with weekly weights, nutrition counseling, and only placing the tube if they hit certain triggers.
Like significant weight loss, say greater than 10% total, or severe dehydration.
Exactly. The argument against prophylactic tubes often cites things like chronic tube dependence, reduced motivation to swallow, maybe some long-term motility issues.
So what's the board say framing?
You acknowledge the debate. You can state that studies have made the decision complicated, but you conclude with a strong evidence-based recommendation. Something like, for a patient with baseline weight loss, high-risk anatomy like base of tongue, plus planned bilateral neck treatment and concurrent systemic therapy, a prophylactic PEG strategy is very reasonable, provided.
And this is the key part.
It is paired with an explicit, rigorous swallow preservation plan from day 1.
That swallow preservation plan is the crucial detail. It's the swallow trap. What happens if we miss that counseling point?
You set the patient up for long-term functional failure. If you tell a patient, hey, you're getting a PEG, just rest your throat, use the tube, they will stop using their pharyngeal muscles.
And that disuse atrophy, plus the radiation fibrosis.
It results in a devastating outcome. Severe dysphagia, permanent stricture risk, and a high likelihood of being tube-dependent years after the cancer is cured. APEG is a tool for calories and hydration, not permission to stop using essential muscles.
We have to get specific with the SLP, right? It's not just about swallowing exercises. What do we need to reinforce?
We reinforce that they have to keep the system moving. Even if it's painful, they must do daily sips of water, actively swallow their own saliva multiple times an hour, and stick to their exercises.
Like the Mendelssohn maneuver.
Right, things like that. Resistance exercises to prevent muscle loss. You explain the analogy. The throat is a joint. If you immobilize it, it fibroses and loses function. We use the tube to prevent starvation, but we use the exercises to preserve function. That counseling point is paramount.
All right, let's move into the clinical decision-making during treatment.
Yeah.
Managing acute toxicity. The one that's guaranteed is mucositis.
The predictable burn. It's entirely predictable. Mucositis peaks around 50 to 60 gray, so weeks 4 and 5. If you are genuinely surprised by grade 3 mucositis in week 5, it means you were unprepared.
You weren't aggressive enough with pain and support in weeks 1 through 3.
Exactly. Proactive surveillance and escalation is the key.
So let's start with prevention and daily hygiene. What needs to be in place before the first beam?
The patient needs a very soft toothbrush. They need to do frequent bland rinses, saline, baking soda to keep the oral environment clean. And crucially, they must avoid commercial alcohol-based mouthwashes.
Or anything with peroxide. It just irritates and dries out the mucosa.
And they have to avoid anything physically sharp, like crusty bread, or chemically irritating, like spicy or acidic foods. And we have to keep reinforcing the smoking cessation. Smoking just combusts the irradiated mucosa.
Okay, so once the burn starts, maybe around week 2 or 3, pain control becomes the critical factor. The philosophy has to be treat early and escalate decisively.
We need both topical and systemic options. Topically, the mainstay is viscous lidocaine. It provides a short window of anesthetic relief, but it's often just enough for them to get a meal down or their meds.
And let's talk about the adjuncts, the compound rinses, the magic mouthwash.
Yeah, these are highly institution dependent, but they usually combine a few things. An antihistamine, like diphenhydramine for coating, an antacid like Maalox, sometimes a steroid or an antifungal.
The evidence for one formulation over another is kind of mixed, but
But the symptomatic relief they offer, that cooling, numbing effect, is invaluable for quality of life and intake.
Systemically, where do we start and how do we escalate?
We start with non-narcotics, so high-dose acetaminophen. Then we can consider judicious use of NSAIDs, but with a huge caveat. We have to watch renal function very closely, especially with cisplatin.
And early opioids. This is where some people get hesitant, but the pain is real.
Absolutely. The goal is not just pain reduction, it's maintaining function. If they're in agony, they won't drink, they won't eat. We need to prescribe short-acting opioids, like oxycodone, early enough so they can swallow meds, maintain intake, and get some sleep.
And what about gabapentin or pregabalin?
We have to consider it. It's often used for that neuropathic component of the pain from nerve fiber injury and inflammation. It adds another layer of relief that simple opioids might miss.
Okay, so beyond the radiation burn, we need constant infection surveillance. These are the add-ons that can turn a tough week into an admission.
The most common culprit is thrush or oral candidiasis. You look for those classic white, creamy plaques that scrape off.
And if it's mild, you can start with topical nystatin rinses.
Right. But if it's severe or really impacting swallowing, you often need systemic fluconazole for rapid relief.
We should also be aware of herpetic reactivation.
You should. Consider it if the patient has atypical ulcers, especially on the hard palate, or if the pain just seems way out of proportion to the visible mucositis. It needs prompt antiviral treatment if you suspect it.
And the third one, bacterial superinfection.
Thankfully uncommon in the mouth, but if you see systemic signs, fever, a foul odor, purulent cellulitis spreading, you have to treat empirically with antibiotics and maybe admit them for IV therapy.
Okay, let's talk hydration management, which you said is the great masquerader.
It is. So many mucositis admissions are really just dehydration admissions. The pain prevents drinking, nausea makes it worse, and they fall into a spiral.
They get dehydrated, which makes them weak and dizzy. And if they're on opioids?
It dramatically worsens the constipation. It creates a whole secondary crisis.
So we need a plan for IV fluids when oral intake drops. We need meticulous electrolyte monitoring, especially with cisplatin.
And never forget the bowel regimen. Proactive stool softeners and laxatives from day one are non-negotiable for any patient on opioids. Preventing that constipation spiral is key.
Okay, we've set the pre-treatment plan. Now let's move to in-treatment monitoring.
Yeah?
The weekly on-treatment playbook.
Right. Every single week, that visit needs a minimum structured assessment. I use a simple mnemonic to make sure nothing gets missed. WIPOH.
WIPOH. Let's break that down.
W is for weight. And we don't just record the number, we trend it. If they lose 3 pounds or more in a week, that's an immediate intervention trigger.
I is for intake. Calories and fluids measured quantitatively. You have to ask for real numbers, right? How many ounces did you drink?
Accepting I'm doing fine is unacceptable.
P is for pain control. Are they controlled? Can they swallow their meds and fluids? If the answer is no, the regimen needs immediate escalation.
O is for oral exam. That means grading the mucositis and, crucially, doing a dedicated thrush check. If you don't look, you will miss a treatable infection that's making their pain worse.
And H is for hydration status. So we're assessing for clinical signs, orthostatics, low urine output, dizziness. This assessment often dictates whether you need urgent IV fluids. WIPOH is your weekly safety net.
It is.
And this systematic surveillance is essential because we have to act immediately on the escalation triggers. When do we intervene and when do we hospitalize?
Triggers for urgent intervention include rapid ongoing weight loss, inability to maintain hydration orally, uncontrolled pain that's preventing intake or sleep despite high-dose opioids.
Systemic distress signs too, right? Delirium, weakness, falls.
That means the patient is crashing systemically, fever, suspected sepsis, or overt aspiration. Those warrant an immediate trip to the ED.
So let's apply this back to our anchor patient. 58-year-old base of tongue, 15-pound weight loss, bad teeth. We deferred the start date. Let's fast forward.
Okay, decision 1 was dental. He cannot start on Monday. He needs that urgent dental evil, probably extraction. We have to delay the start and use that 10 to 14-day healing window for our planning and sim.
Because starting radiation on open sockets invites ORN and a mid-treatment infection that will absolutely force a catastrophic treatment break.
Decision 2 was nutrition. He's a textbook high-risk patient, so we immediately consult nutrition and SLP. And given the baseline weight loss, the consensus should favor a prophylactic PEG tube placed before he's starved and dehydrated.
So a realistic timeline you give the team is dental work now, wait for minimum healing, use that time for planning and PEG placement, and only start radiation once the mucosa is healed and all the supportive logistics are locked down.
And the essential counseling line to the patient is, we are delaying to prevent a complication, a fractured, non-healing jaw that can derail your treatment and cause permanent suffering. Our goal is to start once and finish on time.
That's a message of strength and experience.
Which leads us right into the crisis management of week 5, the break trap. This is when toxicity is at its peak. The patient has grade 3 mucositis, can barely swallow, losing weight, totally exhausted, and the resident suggests,
Maybe we should hold radiation for a few days to let the mouth heal.
this is maybe the single biggest test of clinical resolve in this field. Your answer has to be firm and unequivocal. Breaks are a last resort. The default is to intensify supportive care, not pause curative radiation.
Every day off significantly reduces the biologically effective dose and threatens local control.
So the action plan is always escalation. First, optimize analgesia, aggressive opioid titration, adjuncts. Second, treat infection. Third, aggressive hydration, often scheduled IV fluids or even a short admission. Fourth, nutrition escalation start or increase the tube feeds dramatically. And then, daily reassessment.
We only hold radiation for true medical emergencies. Airway compromise, uncontrolled sepsis, hemodynamic instability.
And if you must hold, you immediately plan compensation to catch up, like treating twice a day on the weekend to minimize the gap.
Okay, let's transition to our board review segment to really solidify this. 4 oral board-style questions.
Let's do it.
Question 1. A patient getting definitive chemoradiation for a T4 larynx cancer develops grade 3 mucositis in week 5, loses 5 pounds that week, minimal oral fluid intake. What's the most appropriate next step? A. Hold radiation for 3 days. B. Continue radiation with intensified supportive care, including IV hydration and nutrition escalation. C. Reduce the daily fraction size. Or D. Stop chemo and radiation until it heals.
The best answer is B. Grade 3 mucositis in week 5 is expected. You have to manage it aggressively to prevent breaks. Holding radiation compromises local control. The correct move is decisive supportive care escalation to keep the radiation on schedule.
Question 2. A patient with an oral cavity primary has multiple non-restorable molars getting 70 gray. Which intervention most directly reduces the risk of osteoradionecrosis? A. Extract the teeth after radiation. B. Pre-radiation dental evil with extraction and adequate healing time. C. Routine prophylactic hyperbaric oxygen. Or D. Prophylactic long-term antibiotics.
The answer is B, 100%. ORN risk is all about high-dose jaw exposure and trauma. The single most effective prevention strategy is getting those high-risk teeth out before the jaw is permanently injured by radiation and making sure it has time to heal.
Question 3. A high-risk base of tongue patient is getting a prophylactic PEG tube. Which counseling point is most important to prevent long-term swallowing dysfunction? A. Once the tube is in, stop swallowing to reduce pain. B. Use the tube for calories and hydration, but keep swallowing daily and do your SLP exercises. C. Avoid all oral intake until 3 months after radiation. Or D. The tube must be removed within 4 weeks.
The best answer is B. This is that critical swallow preservation concept. Disuse atrophy plus radiation fibrosis is a recipe for disaster. The PEG supports nutrition. It must be paired with active swallowing therapy to preserve muscle function.
And question 4, a synthesis question. Name 3 patient and treatment-related factors that strongly favor a prophylactic feeding tube over a reactive approach.
The 3 high-yield factors are 1. Significant baseline weight loss, especially 10% or more. 2. A base of tongue or hypopharynx primary site. And 3. Planned bilateral neck radiation combined with concurrent systemic therapy, especially high-dose cisplatin.
Perfect. Let's wrap up with our clinical pearls and controversies. The final high-yield takeaways and the big mistakes to avoid.
Pearl number 1. Extract before you beam. Internalize it. ORN is a permanent jaw dose problem. You are preventing a decades-long catastrophe by dealing with the dental risk up front.
Pearl number 2. The healing window is not negotiable. Aim for 10 to 14 days minimum. If you rush, you risk an acute infection crisis.
Pearl number 3. Fluoride is for life when salivary dysfunction is meaningful. It's a lifelong medicinal requirement delivered via custom trays. Failing to stress the permanence of xerostomia-induced decay is a major lapse in care.
And pearl number 4. The absolute win is finishing treatment on time with minimal breaks. Treating mucositis and pain aggressively is the only way to preserve the dose and BED required for tumor control. Supportive care enables dose delivery.
And now for the 3 dangerous mistakes. The oral board traps that just instantly reveal inexperience.
Trap number 1. Extracting teeth during radiation. If a patient shows up in week 4 with a severe toothache, the instinct should not be, pull it today.
That is the most dangerous answer. You are opening a non-healing wound in an actively inflamed, irradiated field. The correct move is temporization, antibiotics, pain control, urgent dental consult, and defer extraction for months after treatment, unless it's a life-threatening infection.
Trap number 2, the PEG equals rest your throat mistake.
If you recommend a feeding tube but fail to rigorously emphasize ongoing swallowing and SLP therapy, you've basically sentenced the patient to accelerated disuse atrophy and severe long-term dysfunction. You have to partner with SLP on this.
And trap number 3, casual treatment breaks for mucositis.
Suggesting, let's stop radiation until the mouth heals a bit, is the wrong instinct. It's a common but devastating error.
There.
The correct instinct, the one that saves their chance of cure, is always support harder, more pain meds, more fluids, more nutrition, so we can treat through it.
So in summary, let's bring it all back to the core philosophy here.
The success of the radiation plan is directly linked to the quality of the support.
We have to systematically extract before we beam. We have to feed and hydrate the patient so they finish the full curative course without compromising dose.
And we have to treat mucositis and pain aggressively to avoid that devastating penalty of treatment breaks.
Because supportive care isn't secondary to the radiation plan.
It is intrinsically part of the curative intent. A patient who is cured of cancer but can't swallow or needs reconstructive surgery for a fractured jaw, that is not a clinical win. Mastering supportive care is mastering the pathway to a high-quality cure.
That's the ultimate provocative thought to take forward. Supportive care is part of cure.
Indeed. And we've focused on the acute challenges today. Next time, we'll move beyond treatment and talk about the late effects that haunt our survivors. Chronic xerostomia, long-term dysphagia, aspiration risk, and how our modern techniques like IMRT can really move the needle on long-term quality of life.
We'll also dive into managing established ORN in survivorship.
It's a critical topic.
Complete practice oral boards at radonsmartlearn.com and subscribe for Radon Smart Review for our next session. Thanks for tuning in.